Good afternoon. Today we're going to be talking practical considerations for treatment of lower extremity tendinopathy with rehabilitative exercise. So when we're talking lower extremity tendinopathy, we're talking Achilles tendinopathy, patellar tendinopathy, not so much gluteal tendinopathy, but I did include some hamstring exercises in there that will cover those rehabs, and also some exercises that will cover semitendinosus, distal sprains, which can also have similar rehabilitation protocols. And let's begin. So we're mostly going to be discussing guidelines today, but we can go over a little bit of history. And here we have some cool images over the next few slides by Dr. Hazel Screen over at Queen Mary University of London. Really interesting images of tendon fibrils. You could really see in what the work they put up, the three-dimension, the spring-like nature, their ability to slide and glide in between each other. Very awesome stuff. And I just think it's important that we get our athletes thinking of the anatomy like we do so that we could be on the same page and start our rehabilitation from the ground floor up with a good framework. So just another cool picture. This is a rat Achilles tendon here. But either way, patient education. While we're doing our evaluation, while we're getting to know our patient, we want to also help them get to know themselves as well. The better we could teach our patients, the better patients they can become, the more we could help them to help themselves, the more they can help themselves to help us, right? The less people we have in the training room, especially just doing a bunch of exercises, because most eccentric exercise programs, most rehabilitative exercise programs for tendinopathy take a lot of time, they take a lot of volume. But anyway, let's talk about what your athletes think of their bodies. Sit down with one of your patients, majority of them coming in, you ask them what a tendon is, and they say, oh, it connects muscle to bone. And they're correct, but the most important job of a tendon is its ability to store energy, act like a spring. And I mean, even if you think about it, those images provided by Dr. Helen Screen, you can actually see they act a little bit like a Chinese finger trap as well to resist tensile forces. So both compressive and tensile forces, like a spring. So this game of patient education is kind of a double-edged sword. We have to kind of tell them the knowns and the unknowns and frame them in a way that'll help facilitate getting the most buy-in from them when it comes to their rehabilitation. And that just comes from the practical side of things. And we kind of need to let them know that they are not in tune for a couple of manual sessions and some ice and some stim and, you know, in the middle of the hardest season yet, they're going to be good to go in a couple weeks, right? At the same time, on the opposite end of the spectrum, we don't want to have them be alarmed or aware of anything they might see on ultrasound or MRI. So we do know that MRI and ultrasound are accurate at diagnosing tendinitis or tendinosis, which were classically used to describe, tendinitis is a structural pathology that results in inflammation, and tendinosis is just any type of observable structural change in the morphology of the tendon crimps. Both of those things don't necessarily improve if pain improves. So we can't really use ultrasound MRI as a prognostic. In that study, we had a segment where they took 25 runners and 46% of them were asymptomatic and had Achilles tendinosis in one of their legs. So for treating, I saw this come up several times, this donut analogy, and I like it. So when we're treating patients who have more severe tendinopathies or more fear and they're not really pushing themselves in their rehab, they feel the pain, they sit back down, they don't do anything for a couple weeks, we want to have them think of their tendon like a donut, where their healthy tendon is on the left and their pathologic tendon is on the right. They have the same amount of tissue, it's just the hole in the tendon on the right is the pathologic tissue. And so our whole goal of treatment, our goal for them, their goal for themselves is to get back to having the rest of their good healthy tissue, all that fantastic tissue that they have, being able to support the load and to prevent the overuse and the wear and tear from occurring and making things worse. And so the other knowns and unknowns we have about that is what can happen if rehabilitation isn't great or it is put off, and things can lead into more degenerative changes, which will have more trouble healing down the road. Some clinicians believe that once these things kind of take set, they can't be changed. We're finding other things, but still it's what's known versus what's unknown. We're not quite sure yet. We're still figuring this out as we go along. So we want to focus on what can be done. So if the tendinopathy is being caused by some type of overload, some type of overuse biomechanically, some type of tensile force, we want to learn how to control and load that force, right? If it's two forces, if it's a compressive force and a tensile force and a shear force all at the same time, maybe we won't be able to eliminate all three, but maybe we could do, so let's say in that bottom right picture there, we have a physiotherapist, I believe she's doing a posterior tibialis mode to get some more mobility in the foot, so they'll have less shear force on the Achilles from increased ankle mobility. So while they're playing, while he's using that, he's going to have tensile and compressive forces on it, but with a little bit more subtalar glide in that ankle, now maybe he'll be able to have a little bit more space, so it's not just getting grounded up against his leg, right? So research has shown that multiple forces at different angles and vectors can be more damaging to the tendon. Tendons respond to stress in the direction that they're loaded, and so that's what we're going to be teaching our patients to do in terms of exercise. So if we could limit one of those forces that is not going to be loading the tendon in the direction we want, let's try and minimize it with tape or bracing or whatever evidence-based approach we have in our back pocket. So rehabilitation of tendons is a lengthy process. It is not quick. There are no shortcuts. It is it is a long, slow game. Ran out of time on my recorder, so we're going to have to restart really quick. So as I was saying, rehabilitation is a long, slow grind. And that's not even in terms of just the time of the actual exercise session, but the weeks. And let's kind of get into the specifics of what these programs are going to look like. I mean, first of all, nobody really likes Nordics, and trying to set up a Nordic hamstring at home by yourself is pretty impossible. I don't know if this guy's really being held down by those 15s behind his toes, but let's give the guy some credit and assume that he is. So the first progression, well, I guess you have to find what movements provoke symptoms. We have to try and limit those movements as much as possible, and then we have to find some type of joint position that we can hold an isometric in, pain-free, for up to 45 seconds, up to 5 sets. Once we could do that, we could change angles, lower, higher. So in patellar tendinopathy, they usually do an L protocol where they'll go from 90, 35, 60, several different angles. But you're doing each of these for 45 seconds plus for 5 sets. Time-consuming, painful, boring. But this is better than doing absolutely nothing, and we do know that doing absolutely nothing does not help with recovery. If anything, it's just going to help keep the negative pain, that feedback mechanism of the brain, which keeps upregulation of pain to protect itself going on. So it's going to take a lot of time, and the first progression is not very fun. So we've got people working on Achilles and patellar tendinopathy here. I like these graphics here. I do believe that people should have these in clinic. They're a little small on the screen, but if we let our athletes have a constant reminder and see, oh, how long does it take for this tissue to heal? Now maybe they'll understand that Tenocello is actually, the tendinopathy that we have on this list on the label on the right, 3 to 12 months. Same thing if you look down at the British Athletics Muscle Injury Classification down at the tendinous, same thing, much longer rate of return to play. Slow grind. So now we have some of our other study protocols. So up the top left, that is the Alfredson single leg heel lift protocol, which can sometimes end up being up to 800 repetitions in a day, 2 workouts of 405 repetitions of heel lifts at different angles of knee flexion and at different heights. To me, I would not be able to do that, but certain patients would. Certain patients are so dedicated to get out there and get back out there on the field at something simple they could grind away at 2 times a day, something they know in the back of their hand they can't mess up. That's good for them. They've done studies with this, and they've shown that heavy, slow resistance training was able to provide slightly better results, mostly because it had higher levels of retention and buy-in. So really, is it the modality that's most important, or is it the fact that load is progressing? And load progressing is important. Load progressing in a pain-free manner is important. And also stretching the tendons to load eccentrically how we want them to reorganize is essential, right? So even if it is up for debate whether we actually can get these tendons to, rejuvenate and heal the pathologic tissue, the healthy tissue we have left, we can make strong, keep healthy with activity in the correct parameters. Now, sometimes we could overdo it still with the rehab. Sometimes we can underdo it with the rehab. So this is why we need good mindset to be able to be within a 1 to 3, 0 to 3 pain range, maybe up to a 3 in discomfort, but nowhere in that 4 to 5 range. We might be starting to push a little bit too far. We need to be able to communicate with our clients, that our patients, that tendon pain is going to come a day after an activity, more so than the delayed onset muscle soreness that comes 2 days after. Here we have some more different protocols utilized for patellar tendon loading. Here we have some exercises that are for that distal semitendinosus tendinopathy. But we're going to have to find a way to load. We are not going to have our patients expecting to come in and sit on a table and get iced and get stimmed and get better. Now, those things can help with pain management so that we could do more exercise. Great, let's do them. But those are not the main things that are going to get them better. Those are going to be conjunctions to what they're already doing in terms of their exercise, because we want to be able to progress them once from isometrics to isotonics, ideally 3 to 4 seconds in terms of eccentric and concentric, heavier slow repetition, heavy slow resistance training, followed by plyometrics, and then followed by tendon neuroplastic training, where we take the neuromuscular control aspect of it, and now we are starting to keep a small amount of tension or load or energy in that tendon, and we're beginning to use it like how it's designed to be used, like a secondary static structure just connected to our passive structure, or a passive structure connected to our dynamic structures, right? We want to be able to tell our brain, hey, you can sling this up and down to the metronome or to the external cueing of a light or a partner, so that it's not focused and controlled. Because when they get out there on the pitch, on the court, on the field, it will not be controlled by their brain. They will have to react, call upon their body to get a movement done. And the brain needs to be able to trust that connection, to be able to call upon it safely or with the correct parameters for their performance. So tendon neuroplastic training has some of the highest, the best outcomes in terms of rehabilitation, and this is last, right? So once we get to this level, we can just increase force and speed, bring it back to plyometrics. So now it's neuroplastic plyometrics. But once we get the patient to the level of force and speed and production that they want to get to, they're healed. They're at the level that we were trying to get them to. And I guess that's all the time I have. If you have any questions, feel free to put them down in the chat. Thank you guys very much. Have a lovely day.